right? So what is infarction? Hmm? Okay. Now we have all seen Bollywood movies, Hindi serials, all that. So there is a common scenario, especially 90s movies, that the father hears of the daughter's elopement or something, and then clutches his chest and keels over. What is happening? Infarction. So you know what is infarction. We have all seen it while growing up, right? Or even more common, suffers from a headache and gets paralyzed. What is that? Yes, stroke, cerebral infarction, right? How many students in this class? 150? Puro batch? 1? 149. And how many are present here? Around 50, 55. And then we wonder why students are not able to write anything. They are copying the questions down. Copying the questions down twice for each answer. This is what they are doing. Many of you will be doing it next year. Or this year itself will have your exams next. So you'll be copying the questions down. They can't write basics, they don't listen. So this I've already explained. So it is one of the most common causes, especially myocardial infarction or cerebrovascular accidents. They comprise about 40% of deaths globally. Most common cause of deaths are these. So you have to understand this. What is an infarct? An infarct is an area of ischemic necrosis caused by occlusion of either the arterial supply or the venous drainage, right? So it can be both occlusion of the arterial supply, occlusion of the supply, or occlusion of the drainage. Both can cause an infarct. Which one is more common, you think? Arterial occlusion, right? So why have I included these pictures of plants here? Suppose you have planted a plant, right? But you're not giving it any water. So supply is not there. What will happen to the plant? It will die. But now you have planted a plant in a pot, but there is no drainage hole in the pot. You forgot to put in a drainage hole. You are watering it. You're very religiously watering it every day. Then you are wondering why my plant is dying. Why is it dying now? Excess water. There is no drainage. So there is excess water. Same thing. There is this tissue. Arterial supply is stopped. What happens? The tissue dies. But same thing if the venous drainage is stopped. Artery is going on supplying, but no venous drainage can occur. What happens? Tissue dies. Yeah? Okay. So what is an infarction? Can be localized, can be global also. What are the types of infarction? What? Who answered? Yeah, what are the types? Yeah. Microscopically, what will you find in an infarct? Give me 2 words. What kind? Yes. Okay, difference between red infarct and white infarct? It's self-explanatory. Red in color, white in color. Common organs? Start from the top, go to the bottom. Common organs. Brain and ব্রেনের সঙ্গে connected, something that can give a vision into your brain. Retina, eyes. Retinal infarct can cause blindness. Heart and hearter pashe lungs, then go down. Liver, বাদিকে spleen, মাঝখানে intestines, then go a little down. For females, ovary, males, testis, then হচ্ছে common in diabetics, diabetic foot and gangrene. The toe becomes black and fall off. So an infarct is an area of ischemic necrosis, that is no blood flow, area of ischemic necrosis caused by occlusion of either the arterial supply or the venous drainage. This is for the benefit of the students who just came in, who are still looking at each other. Please read this out, because otherwise you'll be copying the questions. Please, the students who just came in, you're sitting right there, I can see you. Please stand up. Read this out. Read this out. পড়ো, এটা পড়ো। Drainage, right. So now the causes. Now what I've done is the red ones are the most important causes. These yellow orange ones are the next important causes or less common, and these are the least common. So first, arterial thrombosis, right? So you just had a class on thrombosis, right? The class before this was thrombosis embolism. So arterial thrombosis and embolism. You know these cause an infarct, they can occlude a vessel. So these are the two most important, most common causes. When you are asked to write, please do write at least this, thrombosis and embolism, right? Next, local vasospasm. What happens is, the supplying artery is suffering from a spasm, it constricts, and because of that, there is less blood supply. Example of this, Prinzmetal angina, you have heard? Prinzmetal angina, right? It happens in the heart. This is because of local vasospasm. Hemorrhage into an atheromatous plaque. So what had happened is the artery was gradually getting occluded because of atherosclerosis. The atheroma was already forming in that vessel, so it had blocked almost the whole vessel, but still blood was passing through. There was some space left for blood to pass through. Now there is hemorrhage into this plaque. There is still more swelling, and then there is occlusion of the entire artery. There is no blood flow, 100% stoppage. So that is a hemorrhage into an atheromatous plaque. Extrinsic vessel compression. The vessel is fine, right? But say there is a tumor beside the vessel. The tumor is gradually growing larger and then eventually completely occluding it. This can also cause 100% stoppage of blood flow. Torsion of a vessel. Example, torsion, common examples, testicular torsion and ovarian torsion. So what happens, the testis or the ovary, it twists around its pedicle. The pedicle is bringing in the arterial supply, taking out the venous drainage. Now what happens, there is torsion. No arterial supply, and more importantly, no venous drainage. So there is congestion, ischemia. If you don't act immediately, if it is not relieved immediately, then that tissue dies off. So the person loses an ovary or a testis. Traumatic vascular rupture, of course, we all know there is an RTA or any kind of trauma. The vascular rupture, obviously, there is no blood flow. And vascular compromise by edema. This happens in anterior compartment syndrome of the leg, right? Or say you have tied a tourniquet and you forgot to take it off, right? So what happens? There is edema, there is congestion, no blood flow, the tissue dies off. So now you tell me, what is this? These are the causes. What is this? Thrombosis, first important cause. Thrombosis. What is this? Embolism in a lung. The person has suffered from a femoral fracture. What happens? Fracture femoral commonly causes pulmonary embolism. After 2 days, the patient will suffer from an embolism. Next, what is this? Next important cause? Vasospasm. What is this? Hemorrhage into an atheromatous plaque. What is this? Tumor compressing a vessel. Next, the causes. What is this? Torsion. What is this? Traumatic rupture. What is this? Strangulated hernia. So, edema. Next, types. The types of infarct can be most importantly by color, red infarct and white infarct. But also the presence or absence of infection we can classify according to that also. So it can be septic or bland. So red infarct and white infarct, septic infarct and bland infarct. Red infarct. Causes of red infarct. So firstly, it will happen in a case where there is venous occlusion. Venous occlusion will give rise to red infarct, like organs which have one efferent vein. Now what happens is, I already told you and you already know that arterial occlusion is more important cause of infarction or ischemia. Because why? Why is venous occlusion not so important? Why is venous occlusion not life-threatening? Why is venous occlusion not so important? Or not life-threatening rather? Somebody stand up. Because other channels open up and there can be drainage. It is all interconnected. So usually there is not one vein that is going out. So there are other channels. So blood still can drain out. Some amount of blood can always drain out. That is why venous occlusion does not cause infarction usually, except in organs which have one efferent vein, like testis and ovary. These have one efferent vein, and that is why venous occlusion can cause infarction in these organs. And the type of infarction over here is red infarct, because the organ is already congested and then it is getting infarcted. So obviously the red color is imparted by RBCs, right? So that is why there will be red infarct in cases of venous occlusion. Next, in loose spongy tissues. Which is a loose spongy tissue? Lungs, right? So why in lungs? Firstly, it is loose. So there can be seepage of blood. The tissue is not very dense. It's not very solid. It is loose. The alveoli are filled with air. It's loose tissue. So there can be seepage of blood. Seepage of blood continues even after the artery is occluded. The seepage of blood continues in this area. That is why it gives rise to red infarct. Apart from that, tissues with dual circulation, right? Which are the tissues with dual circulation? Again, lungs. What are the circulation? Yeah. And liver circulation? Hepatic and portal, right? Intestines. They are also organs with dual circulation. And forearms, right? Ulnar and radial. So these are the tissues with dual circulation. That is why they will also, because blood seepage will continue, blood flow will continue in these organs. That is why it will give rise to red infarct. In tissues previously congested by a sluggish venous outflow. So already say the venous outflow was already obstructed, and then 100% occlusion occurs over here. So it was already congested. In this organ was already congested. That is why there will be red infarct. When flow is re-established to a site of previous occlusion and necrosis. Say the heart, it was previously occluded. Now you place a stent in that artery. Angioplasty is done and stent placement is done. Blood flow is re-established to this organ. So what happens? It was already infarcted, it is now getting blood flow. Red infarct, right? So this is the lung. This is an example of an infarct in the lung. It's red infarct. Intestines, dual blood supply, red infarct, and this is a testis. I already told you venous congestion occurs in the testis because of torsion, red infarct. Next, white infarct. So what is this? Say this is a solid organ, any solid organ, okay, any tissue. It is being supplied by this vessel, this artery, right? So this is how the artery supplies. It enters and then it supplies the entire portion, right? Now there is an occlusion here for some reason. So what happens? The shape will be wedge shaped. This is a wedge, right? So the shape of the infarct will be wedge shaped, with this triangle kind of thing. And the apex of the triangle will be the area where the artery is occluded. And the entire drainage site will not get any blood, right? So this happens in solid organs. Solid organs like liver, kidney, spleen. Because the tissue is very dense, so there is no seepage, as opposed to the lungs, which is the tissue is loose. So there can be seepage of blood from other areas, but in these tissues, the tissue is very dense, no seepage of blood. So the color of the infarct is red, right? Also heart. Heart is getting supplied from the, do you know where the blood supply of the heart, the myocardium? From subendocardial blood vessels, right? So this is the wedge. This is the endocardium, the inside lining. This is the myocardium. This is the pericardium. So the subendocardial blood vessels are supplying the myocardium from here. There is an occlusion here. So the artery enters from here, this side. So the point of entry, and then there is a wedge shape. Same in kidney. Kidney tissue is also very dense. It gets supplied from the hilum. The blood vessels enter from the hilum. So, say there is occlusion here, wedge shape. This is a spleen. Same, wedge shaped. So, in solid organs, there will be a wedge shaped infarct. What happens is, immediately the time when the artery is occluded, the color will not become instantly red. It will not become like that. What will happen? It will take some time for the changes to happen microscopically, and then gross also, which we will see in gross. The changes to happen, firstly, it takes at least 4 to 12 hours. So, say a person dies, there is a massive myocardial infarction, and then the person dies. Will you see any change? Instantly, the person has died, say within 1 hour. You won't be able to see any this kind of infarct. So, for an infarct to develop, it takes at least 4 to 12 hours, and for a well developed infarct, it takes 1 to 2 days. What happens is, firstly, there will be blood. So instantly, say within 4 to 12 hours, within half a day, it will still be red only, it will be congested. What happens is, inflammatory cells will come in. Inflammatory cells come in and surround the area. And then well developed, the inflammation will be well developed in 1 to 2 days. After that, gradually, the entire inflammatory cells and the tissue dies off, and then eventually it gives rise to the white infarct. Right? Now, say the infarct has occurred, the organ is covered by a serosa. Serosal covering is there. So, around the serosal covering, there will always be some fibrinous exudate. Right? Because the arterial occlusion has occurred, there will be fibrinous exudate on the serosal surface, congestion and inflammatory cells. Okay, I will repeat this again. Ki holo? So morphology. Oh, one more thing, I don't know, because most students, especially in the like the first internal assessment, students are not able to understand the question, and this is the problem throughout in the third internal assessment also. That is why I have written what this means. Say you are asked what is the morphology, students can't understand what is meant by morphology. Morphology means appearance, gross appearance, microscopic appearance. What is etiology? Cause. Please এইগুলো ভুল করবে না. Right, so morphology. Gross, it will be wedge shaped. I have already explained wedge shaped. Arterial pale, venous hemorrhagic. This I have also already explained, that there is a arterial infarct. So there will be cessation of blood flow and the appearance will be red infarct. Whereas in case of venous occlusion, because it is already congested, you are say in a plant, as I had the first example that I took, in a plant, you are watering the plant, you are going on watering the plant, matita ki hobe, kada kada hoye jabe. So the same thing, it will be congested. In case of venous occlusion, it will be congested. So it will be red infarct. And the aging in an infarct, I am going to say it again. So what happens is, when there is an occlusion in a vessel, immediately there will be no change. You will not be able to see any change. The first change appears within 4 to 12 hours. So in 4 to 12 hours, there will be inflammatory cells surrounding the area of ischemia. Inflammatory cells come in. For well-developed inflammation, it takes 1 to 2 days. And eventually, in about 2 weeks, a well-developed infarct occurs and it will become a white infarct. Why is this important? Can you guess? It's not that important for you at your level, but it's important in next year also for forensic. Why? Time of death, right? Or whether the death occurred immediately or the person survived for a few days after the cause. And microscopic, ischemic coagulative necrosis. What is coagulative necrosis? What is meant by coagulative necrosis? You have already had this class. Not studied? একজন বলো, তুমি বলো। মানে জানো coagulative necrosis? Cellular outline is preserved. Coagulative, you need to remember just 1-2 words. আমারও ওইটুকুই মনে থাকে, পাতার পর পাতা আমারও মনে থাকে না। Cellular outline is preserved, mane coagulative necrosis. What is liquefactive necrosis? Cellular outline is not preserved, right? So that is coagulative necrosis. In coagulative necrosis, some inflammatory cells will be there, right? Scarring. Now, eventually, every tissue, say the person survives, what will happen? There will be fibroblasts will proliferate, they will lay down collagen, and there will be scarring in every tissue, including heart. There will be scarring. What happens? The reason for this, say I already said that, no, this I haven't said. A cell survives, the intrinsic property of a cell varies from organ to organ, right? So, say in the myocardium, the cell survives for about 20 to 30 minutes. After cessation of blood flow, the cell will survive for about 30 minutes. That's it. After that, you've lost it. But the fibroblasts present in that tissue will survive, and they can later develop the scar in a tissue. The eventual, if the person survives, the ultimate outcome is always scarring, except in some cases where stem cells are present in that organ. What happens is there is regeneration from the periphery. There can be regeneration in some tissues, like liver. It has immense capacity to regenerate. So in these tissues it can regenerate, but most commonly the outcome is scarring. And liquefactive necrosis organ, brain. For some unknown reason, brain always undergoes liquefactive necrosis. Possibly you've never been to a post-mortem, but it is I think it's a part of your curriculum. Anyway, it was there in mine. So we were taken to the post-mortem, dome kore. So they will open the brain last, and ultimately just liquid comes out. The entire brain liquefies. It's always, I had expected, I didn't know. I was expecting I will see some brain maybe, but no, it was entirely liquefied. So brain, for some unknown reason, undergoes liquefactive necrosis. So here, this is the myocardium. The myocardium, these are scarred tissues. So what happens ultimately in a scarred myocardium? It is not able to transmit the signal properly. So this is scarring. This is actually normal myocardium, and this is the scarred tissue. Here also this is the scarred tissue, and this is the normal myocardium. The more pink area is the normal myocardium. This is the collagen and fibrosis. This is a kidney which has undergone infarction and then replacement by a fibrous scar. Next, look at pictures only. This is from Robbins. All those pictures were also from Robbins. This is coagulative necrosis. So this you can see. What is this? Do you know? Ki eta kidney te glomerulus. So egulo hocche eta hocche glomerulus. These are the tubules, mostly proximal. Anyway, so this is the kidney. It has undergone necrosis. This here, the outline of the cell, inside the cell you can't see anything, but the outlines are preserved and there are some inflammatory cells. So this is the ischemic area. Outline is preserved. As opposed to this, here you can see the sprinkling of this blue dot. What are these? These are the nuclei. The nuclei have all lysed here. So this is the area of necrosis, infarct, and this is the normal. And this is brain, which has undergone liquefactive necrosis, right? The outline, that you can't see anything, it's just all liquid, it's gone. Destruction or dissolution of tissue. Next, septic infarct. It occurs when vegetations in the valves, they will embolize. Say it is a patient is a habitual intravenous drug user, they will get the vegetations in the valves will be infected. This embolizes. Then it will cause septic infarct when cardiac vegetations embolize. There are bacteria present in the emboli. If this goes and blocks, obviously there will be more inflammatory response in this case. Bacteria are present, the inflammatory response will be more. Ultimately, the outcome is same. There will be necrosis, there will be inflammation and eventual scarring. But initially, there will be more tissue response and there will be septic infarct. Or when microbes seed to necrotic tissues, there will, in this case also, there will be septic infarct. There will be pus formation and abscess formation in that area. Now, factors that influence development of an infarct. Obviously, firstly, the anatomy of the vascular supply. What is that? Say there is a lot of anastomosis in that area. So even if one vessel is occluded, it is still getting blood from the rest of the vessels. So obviously this has an impact on the outcome, right? Because this area or this tissue will not die off. It is not having complete ischemia. It is still getting blood from other areas. So anatomy of that, if it is a place where there is a lot of blood supply, a lot of anastomotic blood supply, then that area will not die. And what else? The rate of occlusion. Now, what are the arteries supplying the heart? 3, right? 3 main arteries. Left anterior descending and it's anatomy কবে হলো তোমাদের পরীক্ষা? Circumflex and right, আমার অত মনে নেই, তোমাদেরই মনে থাকবে. So there are 3 main vessels supplying the heart. Now normally there are channels which intercommunicate within these vessels. There are channels which intercommunicate. They may not be very functional, they may be collapsed, but there are channels which intercommunicate. Now say the occlusion is developing gradually. In this case, normally the most common cause is atheroma, right? So the atheromatous plaque takes time to develop. So the atheroma is developing gradually and there is blockage. But the other communicating vessels are getting time to establish, to open up properly and establish a good vascular supply to the myocardium. So what happens in this case? Because of gradual occlusion of that area, the blood supply, even if there is 100% blockage in the main artery, there is still blood supply to the myocardium and the person does not feel the effect, right? This is called double vessel disease, triple vessel disease. Say the person is suffering from triple vessel. What happened in case of Saurav Ganguly recently? Gym korte giye. So he was suffering from triple vessel disease, I think, isn't it? So, but still he was fine. He's a sportsman, he was fine. But now what happened? He was gymming, right? So his cardiac need had increased. So the function of the tissue was compromised only in case of exercise. Otherwise, at rest, he was fine. Because of the anastomotic supply, the blood supply was okay for when he was at rest. But now that he was exercising, the requirement of blood flow was increased. So the function, he could not maintain, the heart could not maintain the requirement, or the function of the heart was compromised, right? Because of the rate of occlusion. Now tissue vulnerability to hypoxia. This I've already said. So the brain, what is the time it takes for brain cells to die? 2 to 6 minutes, right? So brain cells die off. So the brain will give you just minutes to take action, whereas the heart, it gives you about 20 minutes, right? But as I have already said, that the fibroblasts, so that it depends on the tissue. The fibroblasts will survive, Even after 30 minutes, the fibroblasts will survive. And hypoxemia. Now, of course, this is important in case of patients who are already anemic. So already the tissue is suffering from hypoxia because the patient has less blood, less RBCs already. Now the patient is now suffering from some kind of occlusion. There is ischemia. Obviously, in this patient, the effect will be more. This is important in cases of sickle cell anemia. Sickle cell anemia present in sickle cell crisis. They will present with chest pain. Now, effects of infarction. This is basically a revision of what I have already said. So, the effects can be on both ends of the spectrum. On one end, there will be no effect. The person will not know at all that he has survived an infarct because for whatever reason, there was no effect on the tissue, no clinical symptom. As opposed to the person dies. On the other hand, the person can die because of one massive infarction, the person can die. So there can be no effect and there can be death and there can be everything in between, right? So functional disturbances, I've already said, say in angina pectoris. So this person at rest, he is fine, he is okay. Now he is climbing the stairs, suffering from chest pain. What is this? This is angina. Or, during exercise. Intermittent claudication in legs, same thing. So, functional disturbances because of, say, less than 100% occlusion, there is blood flow, but in cases of increased requirement, increased demand, the organ is not able to supply blood adequately. So, there is functional disturbance. Cellular changes which occur, that can be cloudy swelling, fatty change, ischemic atrophy, replacement fibrosis. You just have to know this. And sudden death because of myocardial infarction, cerebral infarction. Now this also, I have already said, this is just a picture. Common areas where systemic infarcts occur: brain, retina, retinal infarct, blindness, brain, stroke, lungs, pulmonary embolism, pulmonary infarct, heart, myocardial infarction, spleen can also, person can suffer from splenic infarct, liver infarct, small bowel, it is an important cause. The person suffers because of, say, volvulus, or the person will come with gangrene, immense pain in the stomach or in the abdomen, and the person will present with gangrene. Kidney also, infarct can occur, and lower extremities, especially in diabetics, there can be dry gangrene. That's it. Thank you.
Anticholinergic drugs. Cholinergic system already discussed. What is the neurotransmitter of cholinergic system? Acetylcholine. Very good. So acetylcholine is involved in various system, somatic system as well as autonomic system, and the ACH, acetylcholine, is the neurotransmitter. It is neurotransmitter in skeletal muscle. Receptors are N, M. Very good. Then acetylcholine also involved in some sympathetic system, light sweat gland, very good, and in parasympathetic system, in ganglion also. Ganglion, the receptor is N. So what are the different receptors then? Muscarinic receptor and nicotinic receptor. Muscarinic receptor, what are the different muscarinic receptor? M1, M2, M3, M4, M5. Panchta. Distribution of M1, M2, very good, M3, rest one, smooth muscles and glands, smooth muscles and glands. কার্ডিয়াক M2 সিম্প্যাথেটিক হয়ে গেছে না সিম্প্যাথেটিক হয়নি এখনো হয়ে গেছে আলফা বিটা হয়নি তো হয়েছে না হয়নি সেটা হয়ে গেছে NM NN and muscarinic receptor neuromuscular blockers are used neuromuscular blocker are used for blocking of NM nicotinic M type of receptor which is present in neuromuscular joint they are blocked by neuromuscular blocker whereas ganglion blockers are blocked different ganglions it may be sympathetic ganglion it may be parasympathetic ganglion and rest muscarinic blockers are atropine is the main muscarinic blocker so there are different regions where acetylcholine can act as a neurotransmitter first thing receptors are different what are the distribution it may be sympathetic it may be parasympathetic sympathetic এ কোথায় থাকে primarily ganglion এ যেগুলো থাকে সেগুলো হচ্ছে NN type of receptors whereas NM type এ সেগুলোকে কে ব্লক করে ganglionic blockers then blocking of neuromuscular junction এখানেও acetylcholine is the neurotransmitter কে ব্লক করে এটা neuromuscular blocker and the rest the muscarinic blockers are primarily atropine and atropine substitute clear এই পর্যন্ত কোথায় কোথায় অ্যাসিটাইলকোলিন কিন্তু প্যারাসিম্প্যাথেটিক as well as sympathetic ganglion এ থাকে ganglion blockers are different and muscarinic blockers are different and last one is neuromuscular blocker তাহলে অ্যাসিটাইলকোলিনের এগেইনস্টে কাজ করার জন্য তিন রকম হতে পারে এক হচ্ছে মাস্কারিনিক ব্লকার NM ব্লকার অর স্কেলিটোমাস্কুলার ব্লকার অর গ্যাংলিয়ন ব্লকার আমরা এখানে আজকে কি নিয়ে আলোচনা করব মাস্কারিনিক ব্লকার অ্যান্টিকোলিনার্জিক্স মিন্স প্রাইমারিলি মাস্কারিনিক ব্লকার বাট অ্যাসিটাইলকোলিনের এগেইনস্টে কাজ করে কে তিনটে একটা হচ্ছে অ্যাট্রোপিন অ্যান্ড ইটস সাবস্টিটিউট মাস্কারিনিক ব্লকার গ্যাংলিয়ন ব্লকার দে ব্লকস অর counteracts the action of acetylcholine in ganglions be it sympathetic or parasympathetic and neuromuscular junction acetylcholine acts on NM type D-tubocurarine type of neuromuscular blockers acts against acetylcholine at that situation clear এই পর্যন্ত now we will discuss about the muscarinic blocker Today we will discuss about the classification of the anticholinergic drugs followed by the pharmacodynamic, how it acts, which systems they involve and how it acts. Then pharmacokinetic and there are some clinical use and ADRs. So anticholinergic drug, we can classify anticholinergic drugs depending upon its source. If natural source is Atropa belladonna from where atropine extract similarly hyoscine also is a natural one then semisynthetic is homatropine synthetic is ipratropium bromide tiotropium bromide where it is used ipratropium tiotropium bronchial asthma so these are the drugs which can be used as a inhalational local or systemic local very good give an example of a drug which can act take inhalationally act systemically budesonide no where it is used in which clinical situation asthma so these are all the three drugs given inhalationally during asthma three group one is anticholinergic, ipratropium, tiotropium bromide. Second is LABA-SABA, long acting and short acting, beta agonist or antagonist? Agonist, very good. And third one is inhalational corticosteroid. All three drugs given inhalationally and they act locally. All these three drugs. So name a drug which given inhalationally acts systemically. পড়ানো হয়েছে কিন্তু ইনহেলেশনাল আর কি ড্রাগ দেওয়া যেতে পারে হ্যাঁ সালবুটামল ইট ইজ এ beta agonist. So all these are acting locally. General anesthetics, halothane, nitrous oxide, these drugs are given inhalationally but acts systemically. কোথায় কাজ করে এরা CNS এ লাংস থেকে গিয়ে সিস্টেমিক সার্কুলেশনে যায় সেখান থেকে গিয়ে ব্রেনে যায় সেজন্য these drugs are act systemically. তাহলে synthetic, semi-synthetic and natural. According to the structure, we can distribute tertiary and quaternary ammonium compound. Ipratropium is a quaternary. Most of these are tertiary, ipratropium is quaternary. According to the selectivity, non-selective and selective. Selective one is pyrangiapine used in bolo rarely nowadays but it can be used or previously used in acid peptic disorder. So it is a specific one. Atropine is a non-selective. This is a selective, only affect M1. Non-selective means it blocks M1, M2, M3. M1 present in the stomach, M2, M3, smooth muscle and bronchial glands, other glands. Derifenacin, it is effect in M3 and it is present in the trigon. It is used in the urinary hesitancy. So mechanism of action, it is a competitive type of blockade. What is the characteristics of competitive? They go for the same receptor. For non-competitive, they go for the different receptor. For non-competitive, that is the important thing. That both competitive and non-competitive, the difference is that they go for the same receptor. For competitive, same site. For non-competitive, different site, but the same receptor. Structurally similar in case of competitive. So they are structurally similar. They bind the receptor in the same site where acetylcholine binds. So it is difficult for acetylcholine to access that receptor. So now if we increase the concentration of acetylcholine, what happens? Do they overcome this effect? For competitive, if we increase the substrate, that means acetylcholine, they will overcome the effect of the atropine. In case of non-competitive, it will not. So atropine and other muscarinic receptor blockers are competitive. Clear? They are structurally similar to the acetylcholine. They go and bind the same site of same receptor. That means M1, M2, M3. If not, if it is for specifically pyrangiapine type M1 or specific M3, then different. But most of this atropine type of drugs and atropine is the non-specific. Clear? This is the core mechanism of action is a competitive receptor blocker. Kon receptor? Not nicotinic. You also remember that atropine, though they block something, other substitute, they are more specific to the muscarinic. The ganglionic blockers are different. Neuromuscular junctional blocker are different. D-tubocurarine is the neuromuscular junctional blocker. They more sensitive in case of glands like salivary, bronchial and sweat gland. Salivary, sweat gland and bronchial gland. Intermediate for the smooth muscle and heart are least sensitive for the gastric glands. Clear? More sensitive, intermediate sensitive, least sensitive. For CNS, atropine causes in clinical dose. In clinical dose, they stimulate followed by a sedative effect. Hyoscine causes sedation effect. Hyoscine, where it is used? Motion sickness. Very good. Mountain sickness e ki drug deowa hoy? Mountain sickness, morning sickness e ki drug deowa hoy? এই দুটো হোমওয়ার্ক কি কি তিনটে জিনিস মনে রাখতে হবে একটা মাউন্টেন সিকনেস একটা মর্নিং সিকনেস এন্ড থার্ড ওয়ান ইজ মোশন সিকনেস থ্রি ড্রাগস ইউজ মোশন সিকনেস এরটা কি হায়োসিন স্কোপোলামিন তাই মানে অ্যান্টিমাস্কারেনিক acetazolamide used in mountain sickness and for morning sickness antihistaminics use. Atropine stimulates the receptors, that is the medullary receptor, vagal receptor, respiratory receptor and vasomotor receptor. That is the medulla, they stimulate this center, medullary centers like vagal, respiratory and vasomotor. In higher dose, atropine can cause cortical excitation, restlessness, disorientation, hallucination. So, belladonna poisoning. Belladonna is the source of atropine. So, in belladonna poisoning, what will be the features? So, there may be hallucination, there may be some disorientation, delirium for the CNS portion. And in case of glands, it is increased secretion or decreased secretion? It decreased secretion. These are the symptoms of belladonna poisoning. What is the symptoms of organophosphorus poisoning? Organophosphorus poisoning? Organophosphorus poisoning পড়ানো হয়নি শিওর হ্যাঁ কি হবে তাহলে ইনক্রিজ স্যালাইভেশন ইনক্রিজ সোয়েটিং ক্লিয়ার for heart they acts M2 in SA node and causes initial bradycardia followed by tachycardia. Initial bradycardia followed by tachycardia. Clear? Then atropine, how they reduce or increase the heart rate by shortening of the AV conduction. AV conduction shortening lead to tachycardia. Atropine does not influence the blood pressure. Dopamine, dobutamine, or beta agonist or alpha agonist, they influence the beta as well as heart rate. But for atropine, it is only the heart rate. The action is on the heart, not the peripheral vessels. Next is eye. Eye te ki hobe? Ki hoy atropine? Dilatation. Dilatation due to relaxation of the constrictor as well as dilatation কিসের জন্য দুটো ভাবে dilatation হতে পারে কি কি একটা relaxation of the sphincter pupil or radial muscle না dilatation কি কি ভাবে হতে পারে adrenergic drugs they causes The alpha agonist, they causes due to the contraction of the radial muscle. There are circular muscle and radial muscle. The atropine affects the circular muscle and alpha agonist affects the radial muscle. Then relaxation of the ciliary muscle, that leads to loss of accommodation. Loss of accommodation due to the ciliary muscle, and light reflex is also lost. Intraocular pressure, it is increased, reduced. So all secretion are reduced. তাহলে কি কি হলো? আই এর চারটে এফেক্ট কি কি বলো? প্রথম কথা আছে মাইড্রিয়াসিস, দেন সাইক্লোপেজিয়া, থার্ড ওয়ান ইজ intraocular pressure increase, and fourth one is decrease lacrimal secretion. চারটে eye effect of atropine in eye, চারটে পয়েন্ট লিখতে হবে। Mydriasis due to the relaxation of the circulatory muscle. Next is ciliary muscle relaxation lead to cyclopegia and loss of right reflex and loss of accommodation. Third one is may precipitate or increase chances of glaucoma, and fourth one decrease lacrimal secretion may lead to dryness of eye. The four effect in eye. Then respiratory system এ কি হবে? ব্রঙ্কোডাইলেশন, আর সিক্রেশনে কি হবে? রিডিউস সিক্রেশন। তাহলে কি হবে? ইন অ্যাসমা or COPD there is a increased secretion and there is a constriction of the smooth muscle of tracheobronchial tree. Drugs like কি ড্রাগ দেবে? অ্যান্টিকোলিনার্জিক, ইপ্রাটোপিয়াম or tiotropium bromide can counteract this. Next one is GIT. GIT তে কি হবে? একটা হচ্ছে পেপটিক আলসার, আর সিক্রেশন কমাবে, মোটিলিটি কমাবে। ডিক্রিজ মোটিলিটি, ডিক্রিজ সিক্রেশন, দ্যাট লিড টু ফার্স্ট একদম মাউথ থেকে শুরু করে ড্রাই মাউথ, রিডিউস অ্যাসিড প্রোডাকশন, রিডিউস প্যানক্রিয়াটিক সিক্রেশন, and bowel peristalsis will be decreased. Dry mouth, GIT, effect of atropine in GIT, starting from dry mouth, then reduce acid production. Third one is there will be reduced pancreatic secretion as well as reduced motility or peristalsis. Genitourinary কি হবে? It will retention of urine. How? At a relaxation of the bladder wall lead to urinary retention, especially if in the patient, elder age male patient who have a benign prostatic hyperplasia or hypertrophy. Sweat gland কি হবে? Decrease sweat secretion through M3. তাহলে কোন গ্ল্যান্ডটা M1 দিয়ে হয়? Peptic. Most of these other glands are M3. Smooth muscles are M3. Heart is M2. It may lead to atropine fever. জানার দরকার নেই হতো। Pharmacokinetic, atropine can be used and it is absorbed. কি কি pharmacokinetic কি কি পয়েন্ট থাকে? Absorption, distribution, metabolism and excretion. It absorbs from the GIT when applied in the eye. It can penetrate cornea. It is all under absorption. Passage it restrict or it cross of blood-brain barrier is difficult for the atropine. Why? It is because it is a tarsi. It is not lipid soluble that much. 50% atropine metabolized in liver and excreted unchanged through the 50% through the urine. Half-life is 3 to 4 hours. Hyoscine is more completely metabolized and better penetration in the blood-brain barrier. তাহলে সেই জন্যই হায়োসিন ইজ প্রেফার্ড ফর মোশন সিকনেস। মোশন সিকনেসের জন্য হায়োসিন কেন প্রেফার্ড করা হয় দেন অ্যাট্রোপিন? বিকজ ইট ইজ বেটার পেনিট্রেট দ্য ব্লাড ব্রেন ব্যারিয়ার। ক্লিয়ার? Explain why we choose hyoscine over atropine for motion sickness. Clinical use, Parkinsonism. Parkinsonism কি হয়? এটা তো পড়ানো হয়েছে ফিজিওলজিতে। হ্যাঁ হ্যাঁ, না কেন হয়? ডোপামিন আর অ্যাসিটাইলকোলিন ডিসব্যালেন্সড হয়। তাহলে কিভাবে করা যেতে পারে? কোনটা কমে? ডোপামিন কমে। তাহলে আইদার আমরা ডোপামিন বাড়াতে পারি অর অ্যাসিটাইলকোলিনের অ্যাকশন কমাতে পারি। প্রাইমারিলি আমরা কি ড্রাগ দিই? levodopa. Levodopa cross the blood-brain barrier and then converted into the dopamine. Now, in some situation, what happens? There are some drugs which can produce Parkinson-like state. Example is drug-induced Parkinsonism. হ্যাঁ, ক্লোরপ্রোমাজিন আরো ভালো এক্সাম্পল আছে। কোন রিসেপ্টর ব্লক করে সেই ড্রাগগুলো? D2 রিসেপ্টর ব্লকার। হ্যালোপেরিডল গ্রুপ অফ ড্রাগ। হ্যালোপেরিডল ইজ এ অ্যান্টিসাইকোটিক। They block the D2 receptor and they produce drug-induced Parkinsonism. Now, in situation where D2 is blocked, you increase concentration of dopamine in the CNS. Is it effective? So we have to then, in that situation, the drug of choice which decreases the acetylcholine concentration in CNS. Then, so in drug-induced or haloperidol-induced or dopamine D2 receptor blockers induced Parkinsonism, we prefer which drug? CNS penetrating anticholinergic, benhexols. Benchtropine and benhexol, they are anticholinergic which can easily cross the blood-brain barrier and they counteract the acetylcholine in CNS. In which situation? Primarily, it is drug of choice for drug-induced Parkinsonism. Which drug that can cause Parkinsonism? Which drug cause Parkinsonism? Haloperidol, D2 receptor blocker. In drug-induced Parkinsonism, drug of choice is centrally acting anticholinergic, benhexol, benchtropine. Clear? Then motion sickness, drug of choice is hyoscine. Next is ophthalmic disorders. In ophthalmic examination of retina, dilatation of the pupil required and cycloplasia required, especially in children. Atropine is preferred in children. Why? Over other anticholinergic? Because their cholinergic system is difficult to counteract with other drugs other than atropine. It is a strong spasm. So for the ciliary spasm, we give atropine in the children for ophthalmic examination, retinal examination or ophthalmic examination where dilatation and cycloplegia is required. Clear? Next, GIT. GIT তে কি হবে? আলসারে পাইরেনজাপিন দেওয়া হতো, কিন্তু nowadays it is not a drug of choice. Drug of choice are proton pump inhibitors followed by some H2 blockers. Rarely use pyrangiapine. But in case of irritable bowel syndrome, colonic diverticulum, dicyclomine and glycopyrrolate still given. It is not atropine, it is atropine substitutes. Atropine substitutes are given. In traveler's diarrhea, along with opioid, some atropine or atropine substitute given. Next is renal and biliary colic. To relaxation, spasmolysis, atropine substitute can be given. Colonic in GB calculus and renal calculi, if there is a colic in biliary or renal. In case of urinary urgency and incontinence, oxybutynin and derifenacin given. Oxybutynin and derifenacin given in urinary hesitancy. Respiratory disorder কিসে দেওয়া হবে? COPD and asthma. কি দেওয়া হবে? Ipratropium and tiotropium bromide. It also used, hyoscine sometimes also used as a pre-anesthetic medication to reduce secretion. Cardiovascular effect. In case of bradycardia, we can use atropine. Maybe it may be due to the sinus bradycardia or bradycardia due to the AV delay, AV nodal delay. Cholinergic poisoning, that means cholinergic মানে anticholinergic মানে atropine, cholinergic মানে organophosphorus. Here atropine given. Mushroom poisoning, atropine given. Hyperhidrosis. Hyperhidrosis মানে increased sweating. We can give some atropine substitute. তাহলে up to this, what are the clinical use? কারণ এক long question এ যে clinical use of atropine and atropine substitute আছে, সিস্টেম ধরে ধরে বলতে হবে কি কি আছে একবার বলো কেউ একজন। ফার্স্ট সিএনএস। সিএনএস এ কি হায়োসিন ইন মোশন সিকনেস আর পার্কিনসনিজম, স্পেশালি ড্রাগ ইনডিউস পার্কিনসনিজম। তারপরে আইতে কি retinal examination or in some case where cycloplegia or mydriasis required. এর পরে লাংসে কি আছে? COPD and pre-anesthetic medication. লাংস হলো, লাংসের পরে হার্টটা বলে দাও। ব্র্যাডিকার্ডিয়া it can be used. Then GIT তে কি আছে? Irritable bowel syndromes and GU, genitourinary derifenacin can be used in hesitancy. Then আর কিছু আছে? আর কিছু নেই। Hyperhidrosis, it can be used in hyperhidrosis. Next is আর পয়জনিংটা যেন মিস না হয়। and poisoning OP poisoning and mushroom poisoning. OP poisoning and mushroom poisoning. Now adverse effect কি হচ্ছে? reduced urination, cannot see. Why cannot see? Because there is a dilatation as well as cycloplegia. there is a dryness of mouth, cannot speak and sit, then cannot diarrhea, reduce the bowel secretion as well as movement. Mydriasis causes blurring of vision, confusion. এগুলো কেন, কোন সিস্টেমের জন্য এগুলো? In higher dose of atropine in CNS they can cause confusion, delirium, hallucination, dry mouth, flushed skin, constipation, urinary retention more commonly having কাদের হয়? Elderly male patient because of BPH. Now some antihistaminics, some CNS drug also have some anticholinergic effect. Explain why came as a, why these antihistaminic drug or drugs used in CNS is not used in elderly patient. যখনই elderly male patient বলবে তখনই সেই ড্রাগটা সবসময় ব্যাক অফ দ্য মাইন্ডে থাকবে যে এটা কোনো কোলিনার্জিক সাইড এফেক্ট আছে কিনা। Atropine and atropine substitutes have that urinary side effects, but some antihistaminic and CNS drug also have some anticholinergic actions. They can be also produce their urinary retention. So whenever explain why is come as a, why this drug cannot be used in elderly male patient, we have to keep in, is there any anticholinergic side effect of this drug? Clear? Increased body temperature, tachycardia. Blood pressure is not involved in case of anticholinergic. Red as a beet, then dry as a bone, blind as a bat, full as a flux, mad as a hen. These are the mnemonics used for belladonna poisoning or atropine poisoning. In belladonna poisoning or atropine poisoning, which are the drugs to be given? Physostigmine. Hot as a hellfire. Contraindication তাহলে followed by benign hypertrophic prostate in elderly male. Tachycardia secondary to thyrotoxicosis or cardiac insufficiency, lead to cardiac insufficiency. These drugs cannot be used there. Paralytic ileus. Paralytic ileus কি মানে কোন সিস্টেমে? EIT. And after any abdominal surgery there may be some ileus. Ileus means there is slow movement of the bowel. It may be due to the, primarily due to the postoperative abdominal surgery, or there may be some hypokalemia or dyselectrolytemia can lead to ileus. In this situation, if we add on drugs which has anticholinergic side effect, bowel movement will be further reduced. Non-selective M blocker in ulcers. তাহলে কি কি এখান থেকে পড়তে হবে? ফার্স্ট থিং, লং কোশ্চেন আসবে, use of atropine and atropine substitute. সিস্টেম ধরে ধরে বলতে হবে কোনটা কোথায় আছে। atropine and atropine substitute, CNS, eye, lung, GIT, তারপরে পয়জনিং, হাইপারহাইড্রোসিস, সব হার্ট, ব্র্যাডিকার্ডিয়া, সবকটা কিন্তু মেনশন করতে হবে, নাম্বার 1। নাম্বার 2, in case of as a short note, atropine poisoning, what are the drugs used in atropine poisoning? Whereas atropine used in what, in which different drugs, which different poisoning? Atropine কোন কোন poisoning এ as a antidote use হয়? আর মাশরুম পয়জনিং। ক্লিয়ার? দেন হচ্ছে যে রিসেপ্টরস গুলো কি কি আছে? M1, M2, M3 ডিস্ট্রিবিউশন, NM, NN, নাও NM আর NNA কোথাও কি atropine substitute is effective blocker or there are some different effective blocker? Effective blockers in NM, nicotinic muscarinic type, M type of nicotinic receptor है, neuromuscular junctional blocker like D-tubocurarine used as a muscle relaxant. Their atropine is not effective for muscle relaxant. Second thing is that acetylcholine is a neurotransmitter of sympathetic system or parasympathetic system. It is a neurotransmitter of parasympathetic system, but it is also has some role in sympathetic system. Sympathetic system and neurotransmitter ke adrenaline noy kintu noradrenaline. It is noradrenaline, not the adrenaline. What is neurotransmitter? নিউরোট্রান্সমিটার কাকে বলে? বলো, কেউ একজন বলো। ইট ইজ দ্য সাবস্টেন্স, synthesis, storage, release from the neuron presynaptic and they affect the postsynaptic. তাহলে কি তিনটে জিনিস, সিনথেসিস হতে হবে, স্টোরেজ হতে হবে and রিলিজ হতে হবে। ঠিক আছে? আচ্ছা, ganglion blockers are different. You have to remember ganglion blocker will discuss in different class, but it is different from the atropine or atropine substitute. Why? They block the ganglion, not the muscarinic receptors. Anticholinergic primarily means the anti-muscarinic. Then what are the organ and how the atropine affects? Pharmacological action of atropine. First line ki, it is a receptor blocker. Key type of receptor blocker? Competitive or non-competitive? It is a competitive type of receptor blocker. Kon receptor? Muscarinic. There may be some specific blocker like M1 blocker, pyrangiapine, derifenacin for M3, or most of these atropine substitutes are a non-selective. Non-selective example, atropine. Atropine itself is a non-selective. Use of atropine. Atropine কোথায় কোথায় ইউজ হতে পারে? ক্লিনিক্যাল ইউজ অফ atropine. হ্যাঁ? সিস্টেমিক অ্যান্ড লোকাল। সিস্টেমিকে কোথায় ইউজ হতে পারে? সাইনাস ব্র্যাডিকার্ডিয়া, এভি নোডাল ডিলে, তারপরে ওপি পয়জনিং, মাশরুম পয়জনিং, অল দিজ আর সিস্টেমিক এফেক্ট। এবার লোকাল এফেক্টে কি হতে পারে? আই। মোস্ট অফ দিস লোকাল, আদার লোকাল এফেক্ট, দ্যাট মিনস in GIT, in case of tracheobronchial tree, all these are atropine substitute. For atropine, commonly systemic and local. Locale কি হবে? Dilatation of pupil. আর সিস্টেমিকে কি হবে? Sinus bradycardia, avinodal delay, then different poisoning.